have her with us to discuss antibiotic use in neonates. And with that, I will hand it over to you, Dr. Aguilar.
Thank you, Dr. Maurice. Good morning, everyone. Yes, my name is Daniela Aguilar, and I am one of the neonatologists here at VWGR. And today's grand rounds is going to be about the use of antibiotics in neonates. Let me see. Okay, so as learning objectives, we have to recognize the key clinical signs, maternal risk factors, and laboratory markers that guide the diagnosis of early and late onset neonatal sepsis. Apply the current guidelines and institutional protocols to select appropriate empiric and definitive antibiotic regimens for neonates with suspected or confirmed sepsis. To demonstrate an understanding of antibiotic stewardship principles by making informed decisions about initiating, narrowing, or discontinuing antibiotics in the neonatal population. I will give a brief introduction, then I will discuss basic science paper about the importance of commensal bacteria in neonates. Then I will talk about sepsis definition, etiology, risk factors, evaluation, and management. In NICUs, infants are frequently exposed to antimicrobial medications as prophylaxis against infection, as empirical treatment as suspected infection, as a targeted treatment of confirmed infection. Most neonatal antibiotic treatment is for suspected rather than proven infection. And researches in several studies suggest that antibiotics are overused in both term and preterm infants. As the national incidence of neonatal early onset sepsis has declined over the past 30 years, this infection presents neonatal caregivers with a difficult clinical problem, an infection with low incidence, high consequence, and non-specific clinical manifestations that can be indistinguishable from normal newborn transitions or conditions of prematurity. Faced with this situation, it is not surprised that newborns frequently are administered empiric antibiotics for risk of early onset sepsis. Schulman et al. Showed 44 variations in NICU antibiotic prescribing practice across 127 NICUs with similar burdens of proven infection, necrotizing enterocolitis, and mortality. This article was published in 2017 in Science Translational Medicine, and it is about how intestinal commensal bacteria mediate lung mucosal immunity and promote resistance of newborn mice to infection. For this project, the investigators showed how enteric commensal bacteria modulate lung immune response. In the image, this crosstalk is mediated by mucosal dendritic cells, which capture signals from intestinal commensal bacteria. Then, chemokine receptor factor regulate trafficking of type 3 lymphoid cells, which migrate to the lungs, maintaining the homeostasis in lung mucosal immunity. The disruption of commensal bacteria interrupts the migratory program of lymphoid cells, impairing their ability to traffic to the lungs and rendering the newborn mice more susceptible to pneumonia. In order to prove their hypothesis, they try to prove each step of this crosstalk. In Figure 8, they expose pregnant mouse dams to a combination of ampicillin, gentamicin, and vancomycin, beginning of 5 days before delivery. Then antibiotics were discontinued immediately after birth, and newborn mice were injected with Streptococcus pneumonia on day of life 4. In figure B, you can appreciate that this early life antibiotic exposure reduced the total number of commensal bacteria. In figure C, 6 hours after infection with Streptococcus pneumonia, they observed an increased bacterial load in the lungs, in the BLL fluid, in the antibiotic-exposed mice, represented in red. They also observed decreased survival in newborn mice exposed to antibiotics, represented in red, as compared to that mice that were not exposed to antibiotic. At the same time, they proved that commensal bacterial reconstitution in antibiotic-exposed mice increased protection to pneumonia and increased survival. To understand the clinical relevance of these findings, they used human samples. They obtained samples from neonates between 34 to 40 weeks of gestational age in 15 babies treated with antibiotics or not. They confirmed the previous observations, finding reduced concentration of interleukin-22 in the BLL fluid from human newborns exposed to prolonged duration of antibiotics. These data demonstrate the importance of commensal exposure in a defined developmental window during the newborn period in the development of pulmonary mucosal immunity in mice. Also potentially explain the association between widespread use of antibiotic and an increased risk of infections in newborn infants. Now I'm going to talk about the definition of neonatal sepsis. Neonatal sepsis is divided into 2 groups based on the time of presentation after birth: early onset sepsis and late onset sepsis. Early onset sepsis is defined as a blood or CSF culture obtained within 72 hours after birth that is growing a pathogenic bacteria species. And late onset sepsis is defined as sepsis occurring at or after 72 hours of life. The current overall incidence of early onset sepsis in the United States is 0.8 cases per 1,000 births. A disproportionate number of cases occur among infants born preterm in a manner that it is inversely proportional to gestational age at birth. Among term infants, early onset sepsis pathogenesis most commonly develops during labor and involves ascending colonization. However, the pathogenesis of preterm early onset sepsis likely begins before the onset of labor in many cases of preterm labor and or prolonged rupture of membrane. Among the risk factors for early onset sepsis in term and preterm infants, we have the clinical diagnosis of chorioamnionitis has been used as a primary risk factor for identifying infants who are at risk for early onset sepsis, presenting multiple difficulties for obstetric and neonatal providers. Although most infants with early onset sepsis are born to women with this clinical diagnosis, specificity is poor. Only a small proportion of infants who are born in the setting of chorioamnionitis develop early onset sepsis. The new definition for suspected intraamniotic infection or chorioamnionitis includes maternal intrapartum fever, either a single maternal temperature of 39 Celsius or a temperature of 38 to 38.9 degrees Celsius that persist for longer than 30 minutes. And one or more of the following: maternal leukocytosis, purulent cervical drainage, and fetal tachycardia. E. coli has been classified as the most common bacteria isolated in early onset sepsis cases that occur among preterm infants, whether defined by a gestational age below 34 weeks or by a birth weight under 1.5 kilos. E. coli is isolated in 50% of preterm infants, and GBS is isolated in 20% of early onset sepsis cases. 10% of cases are caused by other gram-positive organisms, and 20% of cases are caused by other gram-negative organisms. Staphylococcus aureus and Listeria are uncommon causes of preterm early onset sepsis. Studies continue to identify GBS as the most common bacteria isolated in early onset sepsis cases among term and late preterm infants, accounting for 45% of all cases, followed by E. coli in 15% of cases. The remaining cases are caused primarily by other gram-positive organisms, and 5% are caused by other gram-negative organisms. Staphylococcus aureus and Listeria are less common of early onset sepsis among term infants. Because gestational age is the strongest predictor of early onset sepsis, and 2/3 of preterm births are associated with preterm labor, prolonged rupture of membrane, or clinical concern for intrauterine infection, risk stratification strategies cannot be applied for preterm infants in the same manner as for term neonates. In particular, the neonatal early onset sepsis risk calculator doesn't apply to infants born before 34 weeks of gestation. As I mentioned before, there is not a risk calculator for sepsis in preterm infants. However, these are criteria for preterm infants to be considered at a lower risk for early onset sepsis. Obstetric indications for preterm birth, such as maternal preeclampsia or other non-infectious medical illness or placental insufficiency. Birth by C-section and absence of labor, attempts to induce labor, or any rupture of membrane before delivery. Acceptable initial approaches to these infants may include no laboratory evaluation and no empirical antibiotic therapy, or a blood culture and clinical monitoring. For infants who don't improve after initial stabilization, and or those who have severe systemic instability, the administration of empirical antibiotics may be reasonable, but is not mandatory. Then we have the preterm infants who are at higher risk for early onset sepsis, and these include infants born preterm because of preterm labor, prolonged rupture of membrane, intraamniotic infection, and or acute and otherwise unexplained onset of non-reassuring fetal status. The most reasonable approach to this infant is to perform a blood culture and start empirical antibiotic treatment. Very important to mention is that pediatric blood culture bottles generally require a minimum of 1 ml of blood for optimal recovery of organisms. Obtaining a CSF for culture before the administration of antibiotics should be considered if the infants will tolerate the procedure and if it will not delay the initiation of antibiotic therapy. The incidence of meningitis is higher among preterm infants, around 0.7 cases per 1,000 live births at 22 to 28 weeks gestation, compared with the incidence in the overall birth population. And this is because a more immature immune system, more frequent invasive procedures, and lower transplacental transfer of maternal antibodies. In the study of differential early onset sepsis risk among very preterm infants, meningitis did not occur at all among lower risk preterm infants. If a CSF culture hasn't been obtained before the initiation of empirical antibiotics, physicians should balance the physiologic stability of the infant, the risk of early onset sepsis, and the potential harms associated with prolonged antibiotic therapy when making the decision to perform a lumbar puncture in preterm infants who are critically ill. Now we will talk about the risk stratification for neonates born at 34 weeks or more of gestation. A risk assessment includes an individualized synthesis of established risk factors and the newborn clinical conditions to estimate each infant's risk of early onset sepsis. A cohort of 608,000 newborn infants was used to develop predicted models for culture confirmed early onset sepsis based on objective data that are known at the moment of birth, and the evolving newborn condition during the first 6 to 12 hours after birth. The objective data include gestational age, the highest maternal intrapartum temperature, the maternal GBS colonization status, the duration of rupture membrane, and the type and duration of intrapartum antibiotic therapies. The predicted models were used to develop a web-based neonatal early onset sepsis risk calculator, which recommend clinical algorithms that are based on the final risk estimate. The interactive calculator produces the probability of early onset sepsis per 1,000 babies by entering values for the specific maternal risk factors along with the infant's clinical presentation. These are the different predicted values that will be given by neonatal early onset sepsis calculator. Blood culture and clinical observation are recommended for infants with an early onset sepsis risk estimated at 1 per 1,000 live birth, and blood culture and empirical antibiotic therapy are recommended for infants with early onset sepsis risk estimated at 3 per 1,000 birth. The diagnosis of early onset sepsis in term infants include a blood culture, which is the diagnostic standard, and CSF culture should ideally be performed. CSF culture should ideally be performed along with blood culture and before the initiation of empirical antibiotic therapy for infants who are at the highest risk of early onset sepsis. CSF cell count obtained after the initiation of empirical antibiotic therapy may be difficult to interpret. However, physicians must balance the challenges of CSF interpretation with the realities of care. Meningitis was diagnosed clinically in 4% of early onset sepsis cases in CDC surveillance. CSF culture and analysis should be performed if blood cultures grow a pathogen to optimize the type and duration of antibiotic therapy. CSF culture and analysis don't need to be performed in the vast majority of term infants for whom blood cultures are sterile. Empirical treatment should be based on local patterns of antimicrobial resistance. Ampicillin and gentamicin are the first choice for empirical therapy for early onset sepsis. This combination will be effective against GBS, most other streptococcus and enterococcal species, and Listeria. Although 2/3 of E. coli early onset sepsis isolates and most other gram-negative early onset sepsis isolates are resistant to ampicillin, the majority remains sensitive to gentamicin. Extended spectrum beta-lactamase producing organisms are only rarely reported among early onset sepsis cases in the US. Therefore, the routine empirical use of broader spectrum antibiotic is not warranted and may be harmful. Nonetheless, 1 to 2% of E. coli cases were resistant to both ampicillin and gentamicin in recent surveillance studies in the CDC. When early onset sepsis is confirmed by a blood culture, a lumbar puncture should be performed if not previously done. Antibiotic therapy should use the narrowest spectrum of appropriate agents once antimicrobial sensitivities are known. When initial blood culture results are negative, antibiotic therapy should be discontinued by 36 to 48 hours of incubation, unless there is evidence of site-specific infection. Now I will talk about late onset sepsis. The incidence of late onset sepsis is inversely associated with birth weight. Other well-recorded risk factors for late onset sepsis include the long-term use of invasive interventions, such as mechanical ventilation and central lines, and the failure of early enteral feeding with breast milk. This table shows the incidence of late onset sepsis by birth weight. As you can see, the lowest the birth weight, the highest the incidence of late onset sepsis. This figure shows the most common pathogens associated with late onset sepsis. Coagulase negative staphylococci have emerged as the predominant pathogens of late onset sepsis, accounting for 53 to 78% of late onset sepsis in industrialized countries and 35 to 47% in some developing regions. Gram-negative bacilli responsible for neonate late onset sepsis mainly include E. coli, Klebsiella, Enterobacter, Pseudomonas. Candida species is common especially in very low birth weight or critically ill infants. The blood culture remains as the definitive diagnostic tool for neonatal sepsis. Clinical signs of neonatal late onset sepsis are generally regarded as non-specific. The primary clinical findings in a multicenter study were apnea, feeding intolerance, abdominal distension, heme-positive stool, increased respiratory support, and lethargy and hypotonia. Recent studies show that monitoring physiological data constantly displayed in neonates is a promising method to predict proven or clinical sepsis. The greatest advance in this field is the monitoring of heart rate characteristics, and the rationale is that reduced variability and transient decelerations in heart rate, partially mediated by inflammatory cytokines, indicate that high chance of imminent sepsis. A large randomized trial found a good agreement between expected and proven sepsis by heart rate characteristics monitoring, and the sepsis-associated mortality was significantly reduced in neonates whose heart rate characteristic was displayed as compared with the control. In contrast to suspected early onset infection, in which lumbar puncture is somewhat controversial, CSF collection for culture, cytology, and biochemical evaluation is mandatory in suspected late onset sepsis. Due to the potential negative outcomes associated with missed septic cases, empirical antibiotic treatment is initiated on suspicion of late onset sepsis. An ideal choice of antimicrobial agents is to cover the most common pathogens without providing selection pressure for antibiotic resistance. So as a take-home message, when in doubt, you can check the AAP guidelines about early onset sepsis in neonates. And these are the summary points. The epidemiology, microbiology, and pathogenesis of early onset sepsis differ substantially between term infants and preterm infants with very low birth weight. Infants born at 34 weeks or below gestational age can be categorized by level of risk for early onset sepsis by the circumstances of their preterm birth. Infants born preterm by C-section because of maternal non-infectious illness or placental insufficiency in the absence of labor, attempts to induce labor, or membrane rupture before delivery are associated with a relative low risk of early onset sepsis. In these cases, physicians should consider the risk-benefit balance of early onset sepsis evaluation and empiric antibiotic therapy. Infants born preterm because of maternal cervical incompetence, preterm labor, premature rupture of membrane, clinical concern of intraamniotic infection, or acute onset of unexplained non-reassuring fetal status are at the higher risk of early onset sepsis. Such neonates should undergo early onset sepsis evaluations with blood culture and empiric antibiotic treatment. For all infants, regardless of gestational age, when blood cultures are sterile, antibiotic therapy should be discontinued by 36 to 48 hours of incubation, unless there is a clear evidence of site-specific infection. Early onset sepsis in term infants, there is an individualized risk assessment with emphasis on clinical condition and maternal risk factor, just as GVS status, duration of rupture of membranes, and maternal fever. Use of validated tools like the early onset sepsis risk calculator is encouraged for infants about 34 weeks of gestational age to guide decisions of empirical testing and treatment. Initiate ampicillin and gentamicin if there are signs of infection or significant risk factors. Obtain blood culture before starting antibiotics. Perform lumbar puncture if in ill-appearing infants or if meningitis is suspected. If blood culture remain negative and the infant is well appearing, discontinue antibiotic typically within 36 to 48 hours. Okay, thank you so much. Do you guys have any questions?
Thank you so much, Dr. Aguilar. That was a great review of preterm and term neonatal sepsis. One question I had was you discussed using heart rate variability as a good indicator of neonatal sepsis. In any instance, would you be able to use that rather than getting a blood culture, or where does that fit in with the sepsis calculator?
No, there are some neonatal units, intensive care units that use this device that will auto-populate this algorithm, and it's mostly used in preterm newborns. I don't have experience with term infants, but I think it can be used. But basically, it gives you just predicted value based on the heart rate variability of the newborns. And as we know, sometimes these preterm infants can have apnea of prematurity and not just be sepsis or an infection. So we have to take into account the whole situation. And but if we see a trend in the hero score or the heart rate characteristic that is increasing, and you will see on the display that let's say if the day before was 1 and now within the last 24 hours you see a patient that has a calculator of 2 and has stayed 2 and is looking sick. So those are patients that we should consider doing sepsis evaluations. I will start with the blood culture, but I wouldn't just use the heart rate characteristic calculator as a diagnostic tool for neonatal sepsis.
All right, thank you. Not seeing any questions, just appreciation for the review. Thank you. And again, for everyone listening, if you can find the CME code in the chat, and if you are able to fill out the survey, we would greatly appreciate it. Thank you so much, Dr. Aguilar.
Thank you. Have a good day.
You too.